This is a fun but a key chapter to cover. I hope I can bring something addition to your knowledge around nutritional status. Just know that nutrition is essential. It's a basic human need. And so where does the imbalance come from? We'll discuss that. To get started with, there are certain terminologies we have to get used to when we discuss nutrition. Otherwise, we're not going to understand where does the alteration come from. So nutritional status describe the condition of the body related to the availability of nutrients and the use of nutrients. Nutrients provide the energy necessary for performing the activities of daily living and for the growth and repair of body tissues. That nutrition can mostly be derived from the food that is ingested and digested through the digestive tract, but it also can come through to the digestive tract through liquid feeding, not from the food that we ingest by mouth, but food that's delivered by a nasogastric tube or a gastric tube or a peg tube or by simply delivering it directly into the body through the total parenteral nutrition. And that's only used when, in exception, when the digestive tract is bypassed. When if you get it directly into the digestive tract, you're gonna have, malabsorption, or you just had a surgery and you want to bypass the GI tract, and so you pour the food directly into the circulatory system. That when I'm talking about the total parenteral nutrition. So when we're going to define these terms. So energy is measured by calories or gram calories. Okay, and what does calorie mean? It means that it's the amount of heat or energy required to raise the temperature of 1 gram of water by 1 degree Celsius. The kilocalorie or the large calorie equivalent to 1,000 calories is the amount of energy needed to raise the temperature of 1 kilo of water by 1 degree. So what we use is the large calorie is when we're discussing energy metabolism, because the gram calorie is too small. Um, when we talk about calories and how they're produced, the oxidation of proteins provides 4 kilocalories per gram of protein, whereas the oxidation of fats produces 9 kilocalories per gram of fat, and the oxidation of carbohydrates produces 4 kilocalories per gram of carbohydrates, versus consumption of alcohol. It produces 7 kilocalories per gram. And so the next term we want to introduce is the metabolism. And metabolism is an organized process through which nutrients such as carbohydrates, fats, and proteins are broken down, transformed into cellular energy. It enables the continuous release of energy. And so that is it's coupled with a few physiological function, and most of our energy sources come from the food we eat, and so metabolism becomes key because of what are we gonna store and how are we gonna control its release. So when we talk about metabolism, we talk about two phases of metabolism. Anabolism is the phase where metabolism, storage, and synthesis of cell uh, constituents happen, and it involves using or requiring energy rather than synthesizing energy. In catabolism, we see a breakdown of molecules into substances, and those are used in the production of energy. And so at the end of the day, either or, we see that the body cannot store energy as heat. So what it does, it converts the food components to, in order to be able to store it. And those, all the, the carbohydrates, fats, proteins are transformed by the body into intermediary compound. And that is the adenosine triphosphate, the ATP. It is the energy currency of the cell. That's how it's going to be stored in the cell. And it's going to be stored, it's going to be used, it's going to be replenished as well. Um, you're going to see this and you're going to think, oh, okay, what does obesity pertain to this? It is relevant to obesity because the more energy wasted or as heat loss, the less weight you gain. So this is your key if you're trying to lose weight, and that's morally directed towards me. But it's more important to think of it in the sense of, is it important in another context? And when we look at newborns, we'll see that it is important for newborns to maintain their body warmth. So we talk about adipose tissues. 90% of body energy is stored in those fat cells. Those adipocytes, they may be in small groups or in many parts of the body. They act as a cushion, such as in the kidneys. But collectively, they're metabolically active in the uptake, synthesis, storage, and mobilization of lipids. And they're mostly the source of stored fuel for the body. Okay. And it's stored across the body and everywhere. We saw that liver stores some, but it doesn't like to store too much. Otherwise, we're going to get into that fatty liver. And so adipocytes, um, they have a long lifespan, bless their hearts, and they're fully differentiated cells. And that's why they tie the person who's born with the like if you're big at birth, you run the risk of becoming obese. Thank you. I was born overweight baby, so that's where I sit at the uh, predisposition to becoming obese. So, but again, we said we're gonna talk about that postnatal life for the baby, and we need the fat, and we see in the babies they need the brown fat to help them maintain their thermoregulation. And that brown fat makes up only 5% of the body mass of the babies, but it is so important to avoid that hypothermia, which in many cases is the lethal cause of death in premature neonates. And the major function of the brown fat is to generate heat. And it contains a high concentration of specialized mitochondria that enables this process. And as we grow older, that brown fat decreases. Uh, but it's still in very small amount. What we have as adults is more of the white fat. It constitutes 10 to 20% of our adult body weight. 10 to 20 for men, 15 to 25 for women. And that fat cell consists of most of triglycerides, and they have the highest calorie content, and they're a very efficient energy storage. And the one question is around the mechanism of fat loss. It is unknown, but it may be due to increased programmed cell death of the adipocytes. Those adipocytes we talked are the 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 fully differentiated cells that we talked about earlier. Another key term about adipose tissue is that they're seen as an endocrine organ. Because they secrete a number of important factors: adipokines, leptin, cytokines, the TNFs, the tumor necrosis factor, the growth factors. For example, you see the adiponectin. which is an adipose tissue, it's important in insulin resistance. And so many of the substances produced by adipose tissues um, act either locally or at a distance in other organs. They have an impact on your food intake, on your insulin signaling, on vascular function or energy expenditure, and on the homeostatic processes in the body in general. The expenditure of the body energy results from five different mechanisms of heat production, or what is termed thermogenesis. The BMR, basal metabolic rate, resting energy equivalent, diet-induced, exercise-induced, non-exercise activity-induced, and that thermogenesis in response to changes in environmental conditions such as in shivering. And there are factors that affect it. It varies with age, body size, rate of growth, and state of health. So if we talk about basal metabolic rate only, that is the minimum amount of energy expended that is compatible with life. That is what we need to perform our essential activities, maintaining normal body temperature, cardiovascular, respiratory function, liver function, neurological function, kidney function. But you see it varies if based on the skeletal muscle size. So the body size is going to play a role in increasing that. Also, you see it varied from women to men because of the amount of adipose tissue as men as women. It puts them at a different place. So factors that affect the BMR are age, sex, physical state, and pregnancies. And so with aging, you're going to see a decline in that BMR. The REE is used more to predict energy expenditure. And the most accurate way to determine REE, which is the resting energy equivalent, is by doing indirect calorimetry. So you multiply the REE by 1.2 and you predict the calorie needs. A factor of 1.5 usually provides the needed nutrients during repletion, such as when the person is sick or they're in an act of increased metabolic state. We already talked about basal metabolic rate and resting energy equivalent. Diet-induced thermogenesis is that energy that used by the body for the digestion, absorption, and assimilation of food after its ingestion. So the ingestion of a high protein meal, for example, increases the normal metabolic rate more significantly by up to 30%, and that lasts for 3 to 12 hours versus the exercise-induced thermogenesis. It is based on the type of activity, the length of participation, what's the weight of the person, their physical fitness, and so most increased expenditure is going to be related to the most strenuous activity. The non-exercise activity can also be thermogenic, and where we see energy expenditure. Same activity based on the posture. If you're sitting versus if you're standing and doing that same activity, your expenditure is going to be more while standing. The last part we talked about, I talked about non-environmental related thermogenesis. Other than shivering, for example, in response to cold, you're going to have heat produced because of those muscle activity. But also, you see the release of norepinephrine and epinephrine when you're in a condition that is causing them to be produced. For example, stressful situation, you have that sympathetic stimulation. And studies have shown that obese people with persistent excess calorie intake have increased sympathetic activity triggered by leptin, which results in increased thermogenesis and limits amount of weight gain. So that is a way where the environmental thermogenesis can play a role. Not with stress, but with keeping that burning going. The dietary reference intakes are a set of nutrient-based references values, such as the RDAs, the recommended dietary allowances, the AI, the adequate intake, to the acceptable macronutrient distribution range, the AMDR. These DRIs are periodically updated by the National Academy of Science, and it tells us not only what is the acceptable nutritional but value that we need, but also what we need to decrease the risk of chronic disease. So we need, as healthcare provider, to get ourselves familiar with these. And then these recommended DRIs for nutrients, vitamins, minerals, you can find them on the U.S. Department of Agriculture Food and Nutrition Information Center website. But know that these are calculated based on the nutritional need of a person with the gender, height, weight, age, and activity levels taken into consideration. So when we talk about those dietary intakes, what is the recommended dietary intake? So the recommended dietary allowances based on these different uh, governing bodies. We see them, for example, expressed in that percent daily value. And it tells us what is that daily value or that one serving of a food would supply us with. So let's dig into each of them. Calories. For example, you can see that calories, energy requirements are greater during growth periods. So a person requires approximately 115 kilocalorie per kilogram of body weight at birth. That drops down to 105 kilocalorie per kilogram at 1 year of age, and it drops down to 80 kilocalories by 10 years of age. And then during the adolescent, that reduces further to 45. We see it, girls only require 38 during adolescence. And during pregnancy, that is way shifted. So you see women need 300 kilocalories per day above the normal. And so that is how, so you may see that the breastfeeding woman needs an additional 500 calories. When it comes to protein, how much do you need proteins? The average daily protein requirement is 30 to 50 grams, provided that that protein is of good quality and that you have a balanced diet with adequate carbohydrates and fats. Then when you talk about fats, that is the most concentrated source of energy, you know. AMDRs for fat, it varies. So you're going to see different numbers for adults, for children. So there are different levels when it comes to that. But definitely you see highlighted advice around supplementing omega-3 and omega-6 fatty acids because they contribute to the treatment of many disease. So you see they advise you taking omega-3. So you tell me, how can I tell people where to get those? You see fish, walnuts, and flax seeds are rich in omega-3, whereas seeds and nuts are rich in omega-6 fatty acids. And these are can help with cell proliferation, but they also promote inflammation and blood clotting. So so a balanced diet is a key. That's how you want to and would advise your patient. Carbohydrates is another thing that you need to be balanced with it. A carbohydrate deficient diet usually results in the loss of tissue proteins and development of ketosis. That's where the keto diet is mostly weighted on. So then you think of, okay, how much do I need for vitamins and minerals? And vitamins are catalysts in many chemical reactions, so we cannot be without them. You're going to learn in anemias that vitamin B12, folic acid are essential in the synthesis of the red blood cells. So you need to be having a meal that is nutritious and has all a balanced vitamin content in it. When we look at those vitamins, you need to understand that there's two types of vitamins, fat soluble and water soluble. That you, if you only remember the fat, then you'll know the rest are water soluble. The fat solubles are your addict. And so the minerals, what do minerals do? They have many functions. They're involved in acid-base balance, for example, in the osmotic pressure maintenance. So they also are parts of those vitamins, enzymes, hormones, and we see minerals such as iron in the composition of the red blood cells in the heme, and so you so calcium, phosphorus, sodium, chloride, potassium, magnesium, and sulfur. They're present in large amount. That where you see others like iron, manganese, copper, iodine, zinc, cobalt, fluorine, selenium are trace elements. And so these are essential in to be in the diet. We move to fiber. The fiber, it has the it is that non-digestible carbohydrate present in fruits, vegetables, beans, nuts, whole grains. And why do we use fiber? Because of its ability to provide that increased bulk and viscosity of the stool, and thus helps with the gastric emptying. And also it increases satiety, and so when you eat those, you're gonna have that less eating, so that the person will maybe able to lose weight. um, Body mass index is a measure where you can see if you have if you're an obese person or underweight. So obesity is defined as having excess body fat accumulation of multiple organ specific pathologic consequences. Overweight and obesity are a global health problems. There's 2 billion people that are classified as overweight. There's 650 million who are classified as obese out of those 2 billion. We have a pandemic, an endemic of overweight in the United States, where is more than 60% of the population are uh, categorized as obese, and the prevalence in minority groups such as non-Hispanic blacks and Hispanic ethnicity is overwhelming, and um, and in children and adolescents is even more alarming. That the percentage of children between the age of 219 that are obese is now 17%. That has tripled from 1980. So what is body mass index? Body mass index is an indicator based on the height and weight measurement, and it correlates with body fats. The World Health Organization defined those where if your body mass index is above 25, you're overweight. If your body mass index is above 30, you're obese. And the NIH adopted this classification. So the cutoff of 25 as measure of overweight raised that concern, because if you're muscly and not, you don't have fat, do we think about being 25 being overweight? So it is kind of tricky in there. Um, these are the body mass index. And so when you look at anybody that's over 30 in body mass index, you have subcategory in those where you're seeing class 1, class 2, class 3 of obesity differentiated. So ever wondered why do we need to be hungry? And really we need to continue that a nutritional balance. So that built-in mechanism of feeling hungry is to keep that body weight uh, stable, and matching energy intake with energy expenditure or utilization. But you'll see that there are environmental, culture, genetic, and psychological factors that influence how much you eat. And body weight is really controlled by those feedback mechanisms. So hunger is and satiety is a feedback mechanism. Hunger is associated with some sensory perception, like that rhythmic contraction of the stomach, that empty feeling in the stomach stimulates you to go look for food. The appetite is that desire for a particular type of food, whereas satiety is that feeling of fullness, and thus you desire less of the food. And there are two centers in the brain that interact with hormones and neurotransmitter to balance that, to control food intake and energy output. The arcuate nucleus of the hypothalamus is the center for hunger and satiety. There are other centers in the brain that receive those neural input from the GI tract to provide information about what's the status in the stomach. Is it full? Some chemical signals from nutrients, as sugar when it's low. Um, and also some input from the cerebral cortex regarding what smell we're smelling, what sight we're seeing. When we taste some food, it's going to affect the appetite. Neurohormones are responsible for the short-term regulation of the food intake. They either increase feeding or decrease feeding. So you'll see that orexigenic or anorexigenic. So you need to remember those when we talk about anorexia nervosa. Um, and then they play imbalance. So there's like 30 GI hormone genes that play in regulating hunger and satiety, and they control whether we get weight loss or weight gain. So when we talk about neurohormones that are responsible to control those sensations and thus control our food intake, we see that there are neurohormones responsible for short-term regulation, like we said, affecting either anorexigenic or anorexigenic status of the body. We see that there is intermediate on long-term regulation, and that's defined by the amount of nutrients in the blood, such as the sugar level, um, versus when we see um, a weight loss because of the ketogenic diet, and that's by having appetite suppressant effects, because ketones have that appetite suppressant effect. And then we see adipocytes also releasing leptin, um, and the stimulation of leptin receptors in the hypothalamus produces a decrease in appetite and food intake, as well as an increase in metabolic rate and in energy consumption. So there's a balance in between the neurohormones and food intake. So glucose metabolism is controlled by two mechanisms: glucogenolysis, which is the breakdown of the molecule of glycogen that is stored in the liver. If you remember the function of the liver, that glycogen is broken down into glucose, a simple sugar that the body is going to use to produce energy. Glycogen is stored energy like a long chain of glucose, and when glycogenolysis takes place, then we have the breakdown of glycogen into glucose to be used for energy production. Whereas gluconeogenesis is it's the formation of glucose by the liver, especially by the liver, from substances such as fats and proteins. So it's the synthesis or building of glucose. And so also when we talk about heat production, what goes into heat production? We talked about those. Basal metabolic rate or resting energy equivalent, diet-induced thermogenesis, exercise-induced thermogenesis, thermogenesis response to changes in environmental conditions. We talked about these in the beginning of the lecture. We talked also about what variables affect amount of energy used in previous slides. So one part of the nutritional balance formula is to start with an assessment. Check for the nutrition. What are the risk factors? So elements that are included in the assessment. You need to ask about whether the patient has any conditions, pre-existing conditions, coronary artery disease, atherosclerotic disease, sleep apnea, any gynae abnormalities, osteoarthritis, or any gallstones, cholelithiasis, stress incontinence, cigarette smoking, hypertension, high lipid profile, high cholesterol, or low high density lipids, high triglyceride levels, diabetes or pre-diabetes, just hyperglycemia, history of premature coronary artery disease or physical inactivity, lifestyle, sedentary lifestyle. So then also when you're doing those assessments, you need to assess the person's ability to like education level, what are some barriers, what are some readiness for ask the patient to tell you what is their typical diet look like. And we talked about the health assessment, what is the previous medical histories that they come with, but also do that full physical assessment, those questions about what type of diets, drugs they take. Then look at those BMIs, and then you will see that you need some lab studies. We already spoke about some of them, the cholesterol, triglyceride levels, and then looking at the function of the liver, how is their albumin. It's all going to give you the level of nutrition based on what you have. Who's this patient? Who's my patient? What's their level of nutrition? And so we're first concerned with obesity. So if the person is over, and treatment is almost always recommended for any person who comes to the table with a BMI of 30 or higher, and especially or if their BMI is 25 to less than 30, but they have two or more risk factors that we talked about earlier, and they're present here in this slide. Any of those two, in addition to having a BMI between 25 to less than 30, would put that patient at that treatable level of obesity. So when we focus, after we have done the assessment, and that assessment belongs to both patients, whether your patient is obese or your patient having anorexia, you need to do that full assessment, and you build a plan based on that. So if we talk about the patient that's obese in this case, and we've looked at those risk factors, then we need to dig down into those lifestyle behaviors, and target our plan on lifestyle modification by a balanced diet. In the case of obesity, it's going to be a reduced calorie diet, increased physical activity, and also behavior therapy. They should be all combined together as a weight management program. There are pharmacotherapy and surgery available, but only if a person meets those specific criteria. So after we've done the assessment, we collected all those information. Like I said earlier, we have to go and look at that patient readiness to learn, their motivation, their attitude. Do they have barriers for learning? That they don't come to the table acknowledging that they have that, that they need to um, treat that condition. And so many times when we dig down, we're gonna see that there are sometimes misunderstanding what causes the obesity of this specific person. And when we talk about diet therapy, for example, we're going to dig a little bit about the therapies. But before we dig about those therapies, I'm going to cover one more thing. So the two types of obesity are differentiated based on where fat is distributed, upper or lower body obesity. Upper body obesity is mostly referred as central, abdominal, visceral, or male android obesity, where versus lower body obesity is peripheral, gluteal, femoral, female, gynoid obesity. So we're gonna often say the upper body obesity patient referred to as being shaped like an apple, compared with the lower body obesity, more like a pear shaped. And men have more intra-abdominal fat, and women have more subcutaneous fat. And so as men age, the proportion of intra-abdominal fat is going to increase, and when women reach menopause, they tend to acquire more central fat distribution. And then the obesity type, why it's important, because it's gonna be first we determine it based on dividing the waist by hip circumference and comparing the weight measurement and hip measurement, and then you can decide which type of obesity the person belongs to. So you find that upper body obesity is associated with the development of cardiovascular disease, insulin resistance, type 2 diabetes mellitus, and even all-cause mortality is more associated with upper body obesity. What lower body obesity is associated more is a varicose vein in the leg, mechanical problems, but not much the cardiometabolic risks. So we go to therapy and treatment of obesity. We said we have all these types of therapies. So when we talk about diet and diet composition, what is your plate made of? Um, it is individualized, so dietary therapy should be really individually prescribed depending on that person's BMI, their risk profile, and the goals and that plan. It should be realistic. Should have realistic goals. So restricting diets has been down to even 1,200 kilocalorie per day, and even down to 450 kilocalorie of day, where that's called very low calorie diet. And those diets like basically they're building off of protein. um, they usually will cause abnormal heart rhythms. They're associated with the gallstones, cholelithiasis. So these types of diets really need to have a close medical professional observing the person when they go on that diet. More conservatively, restricting the diet to 500 to 1,000 calorie intake of 4 to 5 meals or snacks throughout the day. Portion control is also another effective diet, but definitely the patient has to be part of the formula. Keeping a daily log of all the food that they ate would give them the increased awareness of what they're eating and how much they're eating. One conversation to have is what is in the plate. What is the diet composition? That low fat is encouraged, low carbohydrate is encouraged, high protein is encouraged. Limit daily calories from fat to 10 to 15%. Higher your protein contents in your diet. But also, if you have higher protein diets, you run the risk of running to kidney stones, and so also you're not gonna have as much fiber, so you'll be more at risk of having some cancers, and um, so that is a, a fine line that has to be really looked at versus physical activity. Okay, so physical activity evidence has proven that it decreases the risk of overweight and obesity. Also, it reduces cardiovascular risks, diabetes risk, that weight dietary therapy alone cannot achieve. Uh, Alone, though, physical activity does not achieve weight loss, so it has to be combined. And the goal for others is to be at a minimum having 150 to 300 minutes of moderate to vigorous activity per week to keep that healthy weight. Behavior therapy is that lifestyle modification. It's a key factor in treating weight loss. Stress management, that stress stimulus control. You know, if I smell this smell, I'm gonna eat. If I pass by this place, I'm gonna eat. Problem solving, resolving to eating um, uh, re- um, to reduce stress versus going and facing the problem with coping strategies. And cognitive restructuring, always social support is going to be key in maintaining that behavioral therapy and preventing relapse. And so building that support, joining a team, having a coach. um, Also, again, we're highlighting that with behavioral therapy comes that um, element in a care plan that all your goals have to be realistic. So part of that behavioral therapy is to tell the person that you can't set unrealistic weight loss goals. You can't lose 10 pounds in a week. No, you can't, unless if you starve yourself, which is going to end you up in a hospital and you go back to your square one. So yeah, 5 pounds a week with a good regimen of diet combined with physical activity and behavioral therapy is really a good strategy. There are a few FDA approved drugs that could be used with people with BMI of more than 30. So these medication, they affect the central nervous system. They either block or activate those neurotransmitters that signal hunger or satiety, and so some of them, norepinephrine, serotonin, dopamine, and histamine pathways are manipulated by those medications. So these drugs are need more research on their effectiveness in weight reduction therapy. So, we also seen some movement towards medications that can increase insulin secretion. Uh, then we look at those surgical management of weight loss, and so they're called bariatric surgeries. And this is only resorted to in clinically severe obese, and that is identified as a BMI of more than 40. In those patients, though, that are more than 35 but have comorbid conditions, that have attempted medical therapy but failed to control weight, they can get that surgical therapy. And these are special people with special treatment, and they're even nursed on and cared for on special units because you'll have to get into that specialty. So, in summary, obesity is the excess of body fat accumulation. There are certain few organs that are involved in that pathological condition and the consequence of being obese. Genetic, socioeconomic, cultural, environmental factors, psychological factors, and activity levels can all play a role in the development of obesity. There are two types of obesity, upper and lower body obesity. The upper obesity is more associated with incidence of health risks. The health risks associated with obesity affect almost every body system. Treatment focuses on nutritionally adequate weight loss diets, behavior modification, exercise, building support, and in cases of marked obesity, pharmacological and surgical therapy can be used as treatment. So, on the other end of the spectrum, we have undernutrition, which continues to be a major problem throughout the world, although it has reduced, but still we have 13% of our population globally undernourished. And uh, we still have it also in developed countries, although here it's most commonly seen in pediatrics and older adults. So malnutrition or starvation, here the person does not receive adequate amount of nutrients for the essential body functions. And we covered what an essentially adequate diet should have to provide the adequate energy from carbohydrates, fats, and proteins, those essential amino acids, fatty acids, those building blocks for synthesis and structures of the cells and repair. So we're talking here all these elements plus vitamins and minerals. We need them. We also need them for the enzymes and coenzymes and hormones that are essential in those metabolic processes. And even like we talk calcium and phosphate that are important for the structural components of the bone. So poverty, ignorance, as well as acute and chronic illnesses, and in sometimes self-imposed dietary restrictions uh, are some of the causes of malnutrition. Homeless people, older people, children, uh, uh, often in the poor socioeconomic conditions, have seen those detrimental effects of malnutrition. And so you'll see lack of protein, energy, vitamin, mineral, all these deficiencies, you see them there. So when we cover before we talk about the effects of the malnutrition and starvation, we need to highlight that so many times there is infants, adolescents, pregnant women in not in poor conditions, but that's just because they overlook their nutrition. They get in the undernourished state, regardless of their socioeconomic status. Also, people with Crohn's disease, they're gonna have, when they're in acute state, they're gonna have that inability to absorb nutrients. People with anorexia nervosa or people who are very have that self-imposed concern about their image, body image, or those athletes, they're gonna also end up in that category. So what is the effect of malnutrition? What is going to happen is that there's going to be a depletion of the body's lean tissues caused by that starvation and or catabolic stress. The lean tissues are those fat-free, metabolically active tissues of the body, like the skeletal muscles, the viscera, the cells of the blood and immune system. So, because these are the largest body compartments, their rate of loss is the main determinant of total body weight in most cases of protein energy malnutrition. In infants and children living in underdeveloped countries, we can further differentiate them into two: protein and calorie deficiency and protein deficiency. So, and those both type their pathological changes will also um, differentiate, on the level of immunodeficiency that's going to result from that protein deficiency with both humoral and cellular immunity. What else we're going to see is the fact that when the patient has those malnutrition, especially if they get into any injury or illness, so their protein breakdown is accelerated versus protein building is disrupted. What you're going to see is protein mass loss from liver, GI, kidneys, heart. And so when you see those uh, organs losing those proteins, the liver is gonna not be able to produce those serum proteins, and then you're gonna have decreased immune cells capability or presence, and then wound healing is gonna be poorer, and the body is gonna be less able to fight off infection. And the GI tract is going to have those atrophy, and then they'll have malabsorption, and the loss from the cardiac muscle was going to lead to reduced cardiac output, and so the cycle is only vicious, and so you see them having less or weakened respiratory effort, weaker respiratory function, or compromised respiratory function, and they may end up being having to be treated. And you see the diagnosis is not a single diagnostic measure. You're going to have multiple tests and nutritional assessment, evaluating what they get dietary intake. And in addition to those lab values, the albumin level, the pre-albumin level is a key in determining the malnutrition. Treatment, if it's severe protein energy malnutrition, you need to cover that in addition to fluid and electrolyte abnormalities replenishment. So you're thinking of the calories and the nutrients and the micronutrients. And at the same time, you're thinking of the vitamins and the minerals because they all need to be replenished. Then when we get to eating disorders, we see that they affect almost like 30 million Americans of all ages, irrespective of the gender. And these illnesses, anorexia nervosa, bulimia nervosa, binge eating disorder, they are eating disorders or disturbances in eating. And what happens is that the underlying is a psychological a disorder. You'll see those more in developed societies of all socioeconomic and all ethnic groups, majorly in major ethnic groups. Genetics, biologic, behavioral, psychological, social factors play a big role in the development of this disorder. The person usually is preoccupied with their weight, and they are so focused on the shape that they present with these disorders and those symptoms. So anorexia nervosa usually begins in adolescence, and they're always on a diet, compulsive exercise. They do those purging behaviors with or without binge eating, and so that they can achieve that sustained low weight. And they have disturbed self-image, pervasive fear of becoming obese, obsession with restricted calorie intake, excessive physical exercise, and usually it is more common in men than in women. It is multifactorial, like we said before, genetic influence, but mostly personality traits of perfectionism and compulsiveness, anxiety disorder. It's been also associated with family history of depression and obesity, peer pressure, familiar pressure, cultural pressure, and how an ideal person should look like, the appearance. And so when we're looking at diagnosis, we want to look at what are those characteristics that that person shows. So one characteristic is the refusal to maintain a minimal normal body weight for age and height. So like being within the 85th percentile. An intense fear of gaining weight or becoming fat, and also a disturbance in the way one's body size, weight, or shape is perceived. They also seen with amenorrhea as in women of menarche, and they as I mentioned, they usually have psychiatric disorders coexisting with anorexia nervosa, major depression, obsessive compulsive disorders, and eventually you can appreciate that they're going to have, other than amenorrhea, multiple organ systems that are going to be affected because of the malnutrition that accompanies anorexia nervosa. The second type of eating disorders is bulimia nervosa, and here you have recurrent binge eating activities such as vomiting, fasting, excessive exercise, use of diuretics, laxatives, and enemas to compensate for that behavior of overeating. So the criteria here is recurrent binge eating at least 2 times per week for 3 months, inappropriate compensatory behavior such as self-induced vomiting, abuse of laxatives or diuretics, fasting, excessive exercise that follow that binge eating episode, and then self-evaluation that is unduly influenced by body shape and weight, and four is a determination that the eating disorder does not occur exclusively during periods of um, anorexia of the that's related to the anorexia nervosa. Also, bulimia nervosa is subdivided into two categories. They'd like to divide them into this, like people who indulge in purging, vomiting, or abuse of laxative and diuretics versus people who go on fasting or excessive exercise. Again, this is also associated with the psychiatric disorder, anxiety disorder, depression. Also, there's an association with substance abuse and or risky or self-destructive behaviors. The difference between anorexia nervosa and eating disorder and bulimia nervosa, I mean, is that in the anorexia nervosa, the person tends to be characterized by a weight that is less than the 85th percentile of the normal weight, whereas the people with bulimia nervosa are usually normal weight. Final check the knowledge here. Which of the following best describes the phase of metabolic storage and synthesis of cell constituents? Anabolism is correct. It's the process of cell building and growth. Which of the following is a reflection of a person's metabolic activity, BMI or BMR? It is BMR because it's the measure of the reactions that are taking place in the body. BMR is not a measure of health, but just a representation of the resting metabolic activity. Is this following statement true or false? Anorexia is a genetic condition that can be treated with medication. Anorexia is a psychiatry or related to more of a psychiatric disorder that must be addressed at the root cause. We can treat the symptoms, but the cause is mostly a mental state. And with that, I conclude. Thank you for your attentiveness.